suspect most of you are like me, and you start having these doubts crowd in, anxieties. You have trouble living in day-tight compartments, as William Osler put it, having a list of things to do. And I came across a poem in a British humor magazine, Punch, and I cut this poem out and kept it over my desk for many, many years. But the poem has really taken on deep, which should almost say theological significance for me. And the poem it resonated with me particularly because when I went off to college, I thought I would be a geologist. And this is a poem obviously written about somebody who was a geologist or mineralogist, and it goes as follows. The title of the poem is The Judgment. I dreamed the angels came for me at night. They stood about my bed, severe of mien, and asked one question. What is enstatite? It is an orthorhombic pyroxene, I said, and as I spoke, I heard the jangle of planets crashing down the cosmic seas. I added hastily, its cleavage angle is 87 more or less degrees. If it were 56, not 87, it would quite clearly be an amphibole. In this they led me singing up to heaven, where angel hands received my battered soul. Well, that's the poem. You might say it's kind of a quirky poem, but it grabbed me because the significance of that poem to me was that at least in the portion of your life in which you allow others to pay you for what you do, there's really no substitute for competence and knowing things. So that whatever this guy's battered life might have been, et cetera, he was ultimately held accountable for being good at what he was paid to do. And that is to know about all these minerals, et cetera, et cetera. So they asked one random question, and that was it. And I'd like to think that of the stuff that we're teaching you, and the problem with all this stuff is that everybody thinks their topic is the most important, right? And there's a lot of stuff that you're never going to encounter in life, and the other problem is that half of it's going to be shown wrong. But the problem is there are going to be over and over and over again critical moments in your life in which you really are held accountable for knowing things. This morning I just ran over here from a hospital where I saw two patients. One was a fellow I know who had what looked like a very atypical case of cellulitis on his leg, and he'd also come in with some chest pain, and the question was I missing something? Was this some syndrome that I ought to know? And I wrote a textbook of infectious diseases for primary care, and I think I know all about cellulitis, but I'm really going to have to scratch my brain to see if I might be missing something there. The other was a person with methicillin-resistant staph aureus and having a reaction to drugs and so on and so forth. And so, again, you just always have to kind of check on these things. And I realize that in these handouts that you have, there's a lot of information there, but focus particularly on the stuff that I put in bold, because that's the stuff that I think you need to know and carry home, and that's the stuff that will be emphasized on the exams. So I won't, what is enstatite will not be on your exam, but again, there's just no substitute for knowing a lot of these things, and fortunately, you're not going to have to know it all. You'll eventually go into one or another area of medicine and hang out a shingle that, hey, this is what I'm competent at. But there are certain things that you need to know to be a doctor. Infectious diarrhea. It's a fairly straightforward lecture today, somewhat of a confusing lecture for me to give and for you to take because you have to think of it in terms of, again, both the syndromes and also the pathogens. Worldwide, the single greatest cause of morbidity and mortality, mainly because of the little children in developing countries dying of diarrhea. And what are some of the things that they die from with diarrhea? Excuse me? Dehydration. What are the pathogens that get them? Cholera in a lot of places. What else? E. coli, Shigella particularly. We'll talk about Shigella. Very decisive role in world history. A lot of the great battles in history have been decided by diarrhea, perhaps dating back to the plague of the Philistines in the Hebrew Bible that some people feel was due to shigellosis, and that the hemorrhoids that the Philistines made were hemorrhoids. If you get diarrhea in the tropics, you get hemorrhoids. South might have lost the Civil War because Lee had diarrhea at Gettysburg, it is suggested. Third most common syndrome seen in general practice in the United States. So it is common. And one thing to talk about that's not going to be in my exam is the things that keep you from getting diarrhea and infections. One to emphasize here is the gastric acidity. Antacids and H2 blockers, proton pump inhibitors, things that ablate the normal gastric acid barrier, dramatically reduce the dose of various pathogens required to cause diarrhea, especially in salmonella, et cetera, et cetera. So this is something to know about. The intestinal microflora are crucially important, particularly in what syndrome that, by way of review, what anaerobic pathogen causes diarrhea. We'll talk about this Clostridium difficile, major cause of hospital-acquired diarrhea, and as we shall see, it's a common colonizer of the bowel that is brought out when you suppress the flora with all these broad-spectrum antibiotics that we have. We'll talk about doses of enteric pathogens a little bit. The point to make here for take-home points is that Shigella is highly infectious, shigellosis. It might need only 10 to 100 cells to cause infection, Shigella, so hand-to-hand transmission of Shigella. Where are you going to pick up giardiasis? Anybody? In the woods? That's good thought there. What? Yeah, good. Classically, you're going to go camping in the Rocky Mountains, right, on vacation, and you drink that clear water that tastes so good from cool mountain spring, and lo and behold, it's got Giardia in it. Giardia, only about 100. Amoebiasis, so 2 pathogens. Beyond that, Salmonella, all this a little bit controversial. E. coli takes a lot of contamination. Salmonella, usually, something's got to sit out on the counter for a while. Cholera takes a huge slug of stuff. Cholera does. Almost as much. If you put bacteria in a broth tube, what will they grow up to? 10 to the what? Remember the bacterial growth curve that you had? You got the lag phase, the log phase, the stationary phase, and the climb. What do they grow up to? 10 to the 9. It takes about 10 to the 6 for a fluid to be cloudy on the basis of bacterial growth alone, which becomes an important point in some settings. So that's about as, but remember that about a third of the people in the world drink water in their bottles, and we probably see some bottles of water sitting around here, right? About a third of you. About a third have clean water, and a third have to drink very contaminated water. When I was a medical student, back in the dark ages, there were only a few pathogens that caused diarrhea, and in my lifetime, professionally, all of these have been added. So the list of things that cause diarrhea is quite extensive. The same is true for viruses. We just talked about viral diarrhea. Now there are lots of viruses that do it, of which the most important ones that we'll talk about later are the rotaviruses and the Norwalk agent. And parasites have really exploded. We knew only about amoebiasis and giardiasis, and now particularly with the HIV/AIDS epidemic, lots of others have come into play. So we're going to talk about all of those. One way to look at diarrhea is low volume versus high volume diarrhea, and the more relevant slide is this one. 2 syndromes of diarrhea that you will find useful in practice, differentiating between the squirts and the runs. And I like to ask patients this all the time. The runs where you are doing fine and all of a sudden you just got to go, and you go and you have this huge rushing watery bowel movement. How many of you had that? And I want to ask, might embarrass us. But the runs are small bowel diarrhea. The colon is acting normally. The colon is a reservoir, right? You can live without your colon. We can do a total colectomy and you'll do fine with your little ileostomy bag or whatever, you know. The colon is a reservoir. So it's working normal. And there's no pain on defecation. Blood and white cells are rare. Proctoscopy is normal, and the pain is mostly mid-abdominal. When your small bowel hurts, the pain is around the umbilicus. Large bowel diarrhea is the squirts. Here the colon is diseased. So you go frequently, it hurts to go, and you have a small stool, there may be pain on defecation. You may see blood and white cells in the stool. Proctoscopy will be abnormal, and the pain will tend to be over the sigmoid colon in the left lower quadrant. Which of these two conditions is more serious? Well, both of them can be life-threatening. Small bowel diarrhea, the runs would be typical of classic for cholera. You die from dehydration in cholera, as somebody suggested. It's an incredible outpouring of fluids. In fact, so bad that, they have these cholera cots, and they cut out a hole in the center that you would just lie in down on this cot so you could just kind of run out the bottom there because you're too weak to get up. Large bowel diarrhea, with the syndromes that we see, though, is more apt to portend a bad illness. These are leukocytes in the stool stained with methylene blue. And usually when you see leukocytes in the stool, white blood cells in the stool, that indicates certain conditions and the various infectious causes that do it. We're talking mainly about the squirts. It doesn't have to be an infection. Ulcerative colitis, ischemic colitis can do it. Shigella, shigellosis, enteroinvasive E. coli, including the famous E. coli 0157, C. diff, Clostridium difficile, sometimes salmonella and other syndromes, less common, but these are the major ones that we think about. Fecal leukocytes, so that's big, fecal leukocytes. Fecal leukocytes indicate usually colonic diarrhea. It may be mononuclear here, interestingly enough, or it could be an inflammatory bowel disease. So fecal leukocytes are big. And then one way to look at yet another way to look at diarrhea is by the mechanisms of syndromes that you get related to the gut. And there are several. Toxin production, as in food poisoning, which we'll say a little bit about that, and nothing on the exam for me. Enteroadherence, in which things simply stick onto the mucosa, and this is mainly with the small bowel, things like Giardia and Cryptosporidia. You just see these little things. They're literally little suckers sticking on the mucosa, and we'll show some electron micrographs of that in such a way that your absorptive surface is ablated. You have no absorptive surface, so stuff just goes right through you. Invading the mucosa, things like Shigella and amoebiasis that actually invade the mucosa. And then systemic infection, such as typhoid fever. Among the toxins, I should also mention cytotoxins of C. diff and other things that we'll talk about later. And this looks at some examples of toxins. Preformed toxins, these are syndromes of food poisoning. Various enterotoxins, enterotoxigenic E. coli and Vibrio cholera. And what does a cholera toxin do? It turns on the adenyl cyclase system, right? So that you secrete lots of stuff. And it turns out that toxigenic E. coli does the same thing. As I recall, it stimulates cyclic GMP rather than cyclic AMP. And then various cytotoxins that C. diff, Shigella, and the sugar toxin from E. coli 0157H7, which recently got in spinach of all things, right? Enteroadherence, things that just stick on the gut. We've mentioned Cryptosporidia and Giardiasis. Worms can do that. And then E. coli, there are about 6 or 7 different syndromes of ways in which different E. coli strains can cause diarrhea, and some of them can stick on. Enteroadherence. This shows enteropathogenic E. coli, showing how these bugs literally fuse with the mucosa and along the way the microvilli fall off, destroy the microvilli, and stick on to the mucosal surface. In invasion, some things cause very little invasion at all. Viral diarrhea causes very minimal invasion. Variable invasion, salmonella, etc. Severe invasion, amoebiasis, which we're not going to talk about much in this lecture. It comes in the parasite lecture, but remember the flask-shaped ulcers of amoebiasis. In some places you will read that amoebiasis causes fecal leukocytes, but that's probably not true. You don't really see intact leukocytes in the stool in amoebiasis, although there may, of course, be leukocytes in the bottom of these ulcers. Interinvasive E. coli, and such as E. coli 0157 and Shigella, these invade the mucosa and so are very, very bad. And then things that use the gut as a portal of systemic infection, there are many, many things that do that. And we're not really going to talk about those in this lecture, but just kind of remember that you can ingest things. And what might you ingest that give you listeriosis? Excuse me? Milk? Milk, ice cream, dairy products, bad cheese. But the major syndromes that we're going to talk about are look at diarrhea. And again, this amplifies on what we were going over earlier about the runs and the squirts. Three major syndromes of enteric infection. Non-inflammatory, caused by enterotoxins, proximal small bowel, watery diarrhea, the runs, no fecal leukocytes. Number one, that's the runs. Number two is the squirts, inflammatory, invasion, possibly a cytotoxin in some cases, colon, dysentery, fecal leukocytes present. And the third syndrome is penetrating, distal small bowel, enteric fever syndrome, fecal mononucleocytes. What would be the prototype for the penetrating diarrhea, the syndrome here? Anybody? That's a good idea, and actually amoebiasis, you can get the lesions around the ileocecal valve, and as you know, it goes to the liver. Not quite what I was thinking. It used to be a major cause of morbidity and mortality in the United States, and still is lots of different places. The great triumph of sanitation and plumbing in this country and other civilized countries, or developed countries, should we say. Not sure how civilized we are. Typhoid fever. And remember from your histology, you get the ulceration square in the small bowel. Excuse me? Whose patches? Sure, Peyer's patches. You see these ulcerations of Peyer's patches, and they can be so ulcerated that they perforate. But penetrating diarrhea, typhoid fever. So we look at non-inflammatory toxin diarrhea, cholera, toxigenic E. coli, food poisoning syndromes, in which the onset will be very short, right? Parasites, we've mentioned Giardia and Cryptosporidia. Inflammatory, non-inflammatory diarrhea, neonates, little tiny children, enteropathogenic E. coli, and rotaviruses. Rotaviruses are big. Rotaviruses, little children, old people in nursing homes. Healthy adults in temperate climates, viruses, food poisoning, sometimes parasites. Traveler's diarrhea can be due to lots of things, often more than one pathogen, but the prototype is enterotoxigenic E. coli. Adults in areas of poor sanitation, cholera comes in. In the hospital environment, we'll see Clostridium difficile is now the premier pathogen. Sometimes viruses, including rotaviruses, and sometimes the cafeteria food in the hospital can be the vector for salmonella. And then chronic cases of diarrhea, you think of giardiasis particularly will cause a chronic diarrhea, sprue. And the enteric toxins, we talk about neurotoxins, botulism. Be serious. We'll talk about botulism in an emergency lecture. Enterotoxins, direct effect on intestinal mucosa to elicit secretions. Cytotoxins, mucosal destruction causing inflammatory colitis. Shigella 0157. So I've told you a bunch of things in slightly different ways here. Any questions so far if I'm going too fast? Inflammatory diarrhea, again, colon, dysentery, fecal leukocytes, and these are some of the examples. So diarrhea, what I've been trying to get you to do is to think in terms of the syndrome that it might be. Think in terms of the syndrome. And enteric fever, systemic febrile disease from distal small bowel. Some combination is seen here of fever, headache, rash, things that direct your attention away from the gut. You have to have positive blood cultures, fecal mononuclear leukocytes, and broad differential comes into play here. Typhoid, uracinosis, possibly Campylobacter fetus. And now the rest of the lecture we're going to talk about specific pathogens and hone in on the questions that we'll talk about. And one thing to know about, and mark this well for your exam, are the different syndromes of salmonella. Salmonella. 4 basic syndromes that can cause gastroenteritis, and there are thousands of cases each year in this country, and a major hazard of salmonella relates to eating out in fast food restaurants, right? I've been hired as a lawyer as a witness by the defense in a number of salmonella cases in which it was alleged that somebody got it from this or that fast food restaurant. And in my opinion, it ought to be accepted as a fact in common law that if you eat out in a fast food restaurant, you're taking a risk of salmonella. Just a fact. Common knowledge. Enteric fever from Salmonella typhi. Bacteremia with or without metastatic disease. In the course of gastroenteritis, you can get salmonella in your blood. Usually it will just whistle through your system of macrophages and spleen and elsewhere will take care of it. Some people have a hard time handling it. Famously, people with sickle cell disease and actually other diseases in which you have hemolysis and iron overload blockading the RE system will predispose to salmonella. And we talked about in the skin, bone, and joint session about how salmonella osteomyelitis occurs in people with sickle cell disease, because if they get salmonella in their blood, they may be having simultaneously areas of microinfarction in their bone, which then can serve as a place of least resistance, a locus minoris resistentiae for salmonella infection. Another syndrome that's important to know about, and you may be examined about this, is that salmonella can have a tropism for atherosclerotic plaques. And so it can cause a mycotic aneurysm of the aorta. Mycotic, the word is applied to certain aneurysms. Mycotic is a misleading word because it suggests it's fungal, right? But it's actually used in that sense just to denote an infection, an infectious aneurysm. So if you're over 50 years old and you get salmonella gastronitis, salmonella can get into your bloodstream, whereas it would in one of you just go right through. It can settle out in a atherosclerotic plaque in your aorta, and you'll blow out an aneurysm. And then some people have an asymptomatic carrier state. In medical history, Typhoid Mary, who went from place to place, causing typhoid wherever she went, is a famous example. What organ harbors salmonella? Especially the reservoir, the gallbladder. Typhoid fever has a rash that, to be truthful, I have never seen. Typhoid fever is rare, called a rose spot. Little tiny spots on the abdomen, typically. Non-typhoidal salmonella, widely distributed in nature, contaminates half of the chickens in the United States, unpasteurized milk. Reptiles especially, it's a hazard. People who go out and get remedies made out of rattlesnakes from Mexico for their cancers or whatever might get salmonella. People who buy pet turtles get salmonella. Unpasteurized milk. So salmonella is widespread in the environment. And as I mentioned to you, the standard dogma is it takes a lot of salmonella to cause disease. You can reduce the inoculum by raising the gastric pH. In recent studies, it's been suggested that maybe fewer organisms than we've conventionally thought may be necessary to cause disease from salmonella. Bacteremia in salmonellosis, to reemphasize the point that I've just made, is usually transient. Nothing happens. Sickle cell disease, famously associated with osteomyelitis, atherosclerotic heart disease, mycotic aneurysm, rarely, very rarely, endocarditis or meningitis might result from bacteremia. And the carrier state from salmonella, about 3% of all cases. You worry about food handlers. In my opinion, they used to check the stool for salmonella in people who work for fast food restaurants. Now that's not done so much because, how often are you going to culture their stools? But Hardee's or McDonald's, they might hire somebody who is a salmonella carrier, high association with disease of the biliary tract and gallstones. Salmonella carrier state. Shigella, we've mentioned again, marked this well, very communicable, very low inoculum required to cause disease. Worldwide, extremely important. We see it here in Columbia, see it in nurseries. Not too commonly, but we do see it. There's several strains of Shigella, as you remember. Shigella dysenteriae, Shigella shigei, Shigella flexneri, etc. Shigella sonii, I think, is the fourth major one, of which the Shiga bacillus type 1 is the worst. And the Shiga toxin, and remember this comes into play probably more importantly for us in that you see it with some of these E. coli strains, 0157H7, can cause disseminated intravascular coagulation in the hemolytic uremic syndrome, which, as the name implies, affects both the kidneys with uremia and the blood causing hemolysis. Maybe a biphasic illness, interestingly enough. The history could throw you off. You may start off looking like the runs and then wind up with the squirts. Shigellosis. Lots of different types of E. coli diarrhea. That's the main point to remember. And probably the one that will be the sexy one that will be examined, you'll be examined on, and boards, et cetera, will be the 0157H7, bloody diarrhea with the Shiga toxin, sometimes with the hemolytic uremic syndrome, E. coli diarrhea. Hamburgers in this case, remember the spinach, et cetera, and the Shiga toxin, E. coli, usually beef, many other fluids. A low infectious dose with this. Doesn't take very many. So wash that spinach well and cook it well, which is too bad because the spinach salad is really good, right? A little bit of bacon on it and so on. You like spinach salad? Crampy abdominal pain, again, hemolytic uremic syndrome, sometimes thrombotic thrombocytopenic purpura. Clostridium difficile. The antibiotic clindamycin was introduced in the 1970s and became very rapidly the premier antibiotic for anaerobic infections, and it was found that some people were getting this colitis, and for quite a while there was a huge controversy about what caused colitis from clindamycin. Investigators all over the United States pursued this very aggressively. It was a great regional difference. In some places, up to 10% of people who got clindamycin developed diarrhea, often with colitis. In other places, it was more like 1 in 100. It was found by Bartlett and his group that in 1975 that this was caused by an organism, Clostridium difficile, a previously unrecognized strain of Clostridium that in a hamster model produced a toxin that would then cause diarrhea. And it has at least two toxins, A and B. There's a third toxin now of unclear significance. And it causes a characteristic, it's the most common cause now we recognize of antibiotic-related diarrhea. It can be recognized. It causes a colitis with yellow-white plaques that can progress to a diffuse colitis with something called toxic megacolon, where the colon gets very large, a lot of systemic toxicity, and the colon can perforate and you can die. And this organism is of great concern in hospital medicine now because it can be transmitted around the hospital. And it turns out that in this case it's been well shown that scrupulous attention to hand hygiene with hand washing and the use of disposable rubber gloves between patients is quite preventive. The thing about C. diff, colonization rate 2 to 3% in healthy adults, 20 to 40% in hospitalized patients. This slide is probably not on your computer, is that correct? It's not on it? That's because I added this slide and two others last night. Excuse me?
It's in the new version?
Yeah, it'll be on that one. So, based on an article that came out last week, I decided to update the slide. Widespread contamination of hospital environments. Hand washing, including gloves, has been shown to reduce infection rates. So note that point and this point real closely. And this is a picture looking with the colonoscope, slightly out of focus probably, but the point is that everything should be pink there. These whitish plaques, which are loaded with polymorphonuclear leukocytes. C. diff, of course, is the Clostridium. It's a gram-positive bacillus. This is a case of toxic megacolon, showing this colon, instead of being nicely pink throughout, is hemorrhagic throughout, again with these plaques on it, these yellowish plaques, a lot of hemorrhage, and the entire colon had to be removed. There is now, in the past 5 years, there's a new epidemic strain of C. diff that we've not yet seen in Columbia. We had a person who was transferred from an extended care facility, got C. diff in the hospital and died of toxic megacolon in Richland, and we were concerned it might be our first case of this. We had not yet seen it here, but there have been outbreaks in the United States of a new strain of C. diff that's a lot more serious, with a mortality rate attributable to the infection of 17% versus 1% for other strains with treatment. More serious and refractory with increasing rates of toxic megacolon disease requiring colectomy, shock, and death. And this has been given a name, don't memorize stuff like this, but, called B1NAP1. It's been given a name. So there's a new strain out there. So this could be for you like methicillin-resistant staph producing the Pantin-Valentine leukocidin factor. This could be a pathogen that you'll deal with the rest of your professional life. And this is another new slide that I'm not going to examine you on, but it produces much larger quantities of toxin A and B. And just to kind of show you how this molecular stuff that you've been reading about will be important for keeping up with the literature. Looking at the genome, it's shown that you can actually type the toxin that's produced. This strain is of a particular toxin type, and it shows from its genome a deletion of a little bit of a base pair sequence in the pathogenicity locus that's responsible for downregulating the amount of toxin that's produced. So that, again, correlates genetics with what we're seeing clinically. It also produces a binary toxin, and it's resistant to quinolone antibiotics. And so what's been found in Canada and elsewhere is that some of the newer quinolone-type antibiotics are tending to promote the appearance of this. Any questions about C. diff? Campylobacter fetus, subspecies jejuni, is a fairly important cause of diarrhea. usually self-limited, cramps, anorexia, weight loss. You may see blood. So this could mimic, sort of overlaps in my mind, both Salmonella and Shigella. Tends to be sort of milder like Salmonella. Blood at 60%, polyism 78% like Shigella. Yersinia is one that you don't see very much in this country, but is apt to show up on exams, particularly for the syndrome of pseudoappendicitis, mesenteric adenitis, and terminal ileitis with fever, right lower quadrant pain, and leukocytosis. So people will be taken to surgery for suspected appendicitis and found to have a normal appendix with some big swollen mesenteric lymph nodes. It can also cause, we talked about reactive arthritis. A lot of reactive arthritis can occur with Yersinia as well. Can cause sepsis, can cause enterocolitis in younger people. So just remember you saw Yersinia, and remember that pseudoappendicitis type of syndrome. There are actually two Yersinia species of medical importance, enterocolitica and pseudotuberculosis. The latter is more famously associated strictly with the mesenteric adenitis. If I were in your shoes, I wouldn't clutter my mind with those. I would just remember Yersinia generically there and not clutter my mind with the two types. But remember that Yersinia can cause mesenteric adenitis. Vibrio there are two Vibrios of importance, of lots of, well, of course, cholera is a Vibrio too. What's a Vibrio? A little gram-negative, comma-shaped bacterium. Besides Vibrio cholera, Parahemolyticus and Vulnificus, both associated with shellfish and seafood. This is often epidemics here. You might get this after see an epidemic after a crawfish boil, for example. Diarrhea, cramps, fever, headache, may have fecal leukocytes. So Vibrios, think of shellfish, Vibrio parahemolyticus, and Vibrio vulnificus, usually an extraintestinal pathogen. That is, diarrhea is not that important thing. And remember, for exams and life, that people with raw oysters, people with cirrhosis should not eat raw oysters because of the risk of septicemia. And we talked about Vibrio vulnificus causing a bad cellulitis. Cholera, the 01 serotype is a really bad one, watery diarrhea. Non-01s, less severe, can have blood in the stool with these actually, often with traveler's diarrhea. This is the one that famously turns on the adenyl cyclase system. And then in the cellulitis lecture, or the skin infection lecture, we talked about Eromonas hydrophila. Hydrophila suggesting water, right? Fresh water. This pathogen can also cause diarrhea in the summer months. In parasitic diarrheas, amoebiasis is a common pathogen worldwide and often seen in the United States. The flask-shaped ulcers that we talked about here, like an Erlenmeyer flask. Liver abscesses, goes from the ileocecal region up to the liver, usually in the right lobe of the liver. And these are the areas that it tends to infect. Around the ileocecal valve and then in the rectus sigmoid area. And this shows amoebae with ingested red blood cells, and these can be mistaken for polymorphonuclear leukocytes in stool. And this shows a cyst. There's another amoeba species. It looks identical to this. In Giardia, we talked about camping in the Rocky Mountains. I should change that, shouldn't I, to St. Petersburg. It can cause diarrhea by several mechanisms, and a chronic diarrhea with weight loss, diarrhea, unpleasant to be around. Giardiasis. This is looking sideways, the trophs of Giardia. And here are the cysts of Giardia. Let me see. Cryptosporidia causes, how many of you grew up on a farm? Anybody? You did? Grew up on a farm? So what are scours? Scours? We didn't ask her what kind of farm. Diarrhea in a calf. So it causes scours. Affects numerous animals. But really, we began to recognize this with the HIV/AIDS epidemic. In healthy adults, it causes a self-limited diarrhea, but in AIDS patients, diarrhea lasting an average of 5 months with a high mortality rate. And these are the cryptosporidia, and this shows how this organism just infuses to the basement membrane of the gut with the villi dropping out. So you can see how this would just massively parasitize the gut. And early on in the AIDS epidemic, the tragedy that I saw again and again was people, and I'd visit them in their homes with diarrhea who were too weak to get up to go to the bathroom. Lots of animal species infected with it. You can get it in the community. And it got into the water supply in Milwaukee on one occasion and infected 400,000 people. We'll close with just a word or two about viral diarrhea, rotaviruses, sporadic epidemics in institutions, infants and young children, fecal oral. There's the DNA virus. There's an ELISA test for it. And Norwalk, typically epidemic. You might get this on a cruise ship or something, often tied to a common source throughout the year, usually older folks, adults, and older children. And we're going to skip traveler's diarrhea, Montezuma's revenge, the Aztec two-step, et cetera, et cetera, et cetera. Just to remind you about lots of different pathogens, especially enterotoxigenic E. coli. Any questions?